So we're joined today with Dr. Conrad, Jens Jorgensen, Dr. Rossi, Dr. Gable, Dr. Scally, and then our data manager, Donna Fleming. So here's our first ARS question. There was a motor vehicle accident patient that presented with a dissected aorta and multiple fractures. He had an emergent TEVAR with a left leg thrombectomy and fasciotomies. Several days later, he developed a DVT in his right leg. Is the right leg event abstracted as a post-operative emboli/ischemia? Yes or no? Very good. Does the panel want to, someone want to help us understand why it would be a no?
I'll give it a shot. Sal Scally, how are you? At least when I read the clinical scenario, it looks like, when I think of emboli and ischemia, I'm almost always thinking arterial, 1. 2, this just seems like a post-op DVT in the right leg, and I don't usually associate DVT with an emboli or ischemic event, and so I don't even associate those things together, so I didn't think of it that way.
It's a post-op complication, but not an emboli or ischemia.
Yeah, so I think it would still get abstracted in the long-term follow-up stuff, right?
I don't believe we.
Because
Donna,
you still did a TEVAR in somebody, and although I agree with Sal, it's not. I don't think it's related. I think it's venous. It's not arterial.
Correct.
But it's still a post-op event.
Donna, I'm going to have to rely on you to help.
Long-term follow-up, I don't believe that would be in
No,
there.
it would be intra-op or
in-hospital.
post-op.
Yeah.
For the
Yeah. No, I don't believe so.
Yeah, that's what I was going for.
So our next question, patient has bilateral iliac aneurysms as a primary indication, and they are repaired using stent grafts. A fusiform aortic aneurysm, which is 3.5 centimeters, is repaired at the same time. Is this surgery entered into the EVAR registry?
Yeah, so as the chair of the EVAR registry, guess I'll kick off on that one. So this would be a case that should be captured in the VQI EVAR registry. I think the confusion comes from the fact that one of the exclusion criteria is an isolated degenerative unilateral iliac aneurysm. So for this particular case, there is an aortic aneurysm with a concomitant iliac aneurysm, so that should fall into the registry.
And I think it's important when we're doing studies looking at EVARs to identify these patients and exclude them, because you always get something from the VQI that is, a certain percentage of the aneurysms being treated are very small, and so someone wants to say that we're doing bad surgery, and I think that that can be a problem when you're looking at a large database if you're not looking at the reason for the repair.
I would agree with Mark on that point, but I do think the quality reports, when they talk about small diameter aneurysm repair, specifically excludes if iliac aneurysm was included. It's only isolated degenerative infarenal aneurysms without concurrent iliac aneurysms that are used in that description in that report that the centers received. But for research purposes, yes.
So a patient with a history of an open AAA repair for a juxtarenal aneurysm 1 year ago. A month ago, the same patient presented for a scheduled type B dissection repair with TEVAR. Entry zone equals zone 3, distal zone of zone 9. Is this an inclusion into the TEVAR registry, even though the new graft relines an older AAA graft? Yes or no? Do you agree?
I'm not sure who would say no to that. At least, I haven't put a ton of cases into the TVAR registry. A lot of times it's the abstractors, but I thought this would qualify a remote history of infrarenal aortic surgery, and then they subsequently present with an acute complicated dissection and gets a TVAR, particularly if, TVARs nowadays may have extension, as my colleague just said, with a petticoat stent that easily could get into the paravisceral segment. And so I believe this does qualify, but I'd be curious to know for those who thought it didn't, what the rationale might have been.
I would also say, or comment that it's a different pathology. So for that reason, I think it does qualify. This particular case does qualify. My question maybe for the rest of the panel would be, suppose this was growth of an aneurysm above your previous repair, and you did this repair. Would that then qualify for inclusion? Or is that something that is an extension of the prior EVAR? Or how would you record that?
So at that point, are you talking about then doing something fenestrated or extending and doing complex EVAR, which, it gets into the complex EVAR, TVAR registry, but it kind of brings to mind the question, like, as we get more and more complicated with things that we do, we almost need like an EVAR plus, right? We like putting pluses after how we identify things nowadays, but a plus behind EVAR for people that have an EVAR that's not fenestrated, but includes other stuff. Think if you're doing an EVAR with a femoral endarterectomy or EVAR with a bypass at the same time, it's not the same animal as a percutaneous bilateral femoral access infrarenal EVAR. Some of that stuff is not getting captured maybe quite as well. It's not necessarily applicable to this exact question, but it brings all that stuff to mind. You can't really be held to a one-night length of stay as a quality metric for EVAR if your EVAR includes bilateral femoral endarterectomies at the same time, because you have to do that for access or because they also have concomitant ischemia.
Well, and the reason I bring it up is, at least at our center, as FEVAR becomes more popular and used more often, we're actually seeing, let me back up. As it becomes more popular and used more often, I think that operators are becoming more willing to accept a shorter landing zone for a straight-up EVAR, knowing that they have maybe a bailout. And so we're seeing more people referred that now have either a type 1A leak or something that need an extension proximally. And so for other operators out there that may have experienced the same thing, that's why I bring it up.
At least for the scenario, if they've had a previous open repair and they have a paranastomotic degenerative aneurysm or further degeneration in the paravisceral or thoracoabdominal aorta, at least looking at the criteria that everybody has in their booklets, that would be captured in the TVAR, complex EVAR scenario. But to Dr. Gable's point, obviously we're increasingly going to be seeing EVAR referrals that have late failure that then get some type of complex endovascular remediation. And I think that would be captured because we didn't have if that wasn't an index VQI EVAR, and then you're now doing a complex endograft remediation of a previous EVAR, I think that gets captured on the intake form for the pre-hospital history. It'll say whether or not they've had a previous device and or open repair.
All right, so now we'd like to open up for live questions. So since we're talking, go ahead.
Hi. I couldn't quite hear your answer about the question with the small aortic aneurysm and the large iliac aneurysms. And I have a surgeon who's brought this question up a few times, so I'm really interested in hearing your feedback.
So for the EVAR registry, it would include that case because the patient had a 3.5 centimeter infrarenal AAA and bilateral common iliac aneurysm. Mm-hmm. It's the isolated unilateral iliac aneurysm cases that are excluded. Mm-hmm. But aortoiliac aneurysm, combined disease, is included in the EVAR module.
That's what I thought. Thank you.
So Sal, how would you handle it? I'm getting a lot of these now. So you have like an infrarenal aortic repair in the past, and now we have either a pseudoaneurysm or aneurysmal degeneration right at the distal anastomosis. So I'm treating those with EVAR, and I'm putting them in. Should we not be doing that?
Yeah, if it's, I believe the EVAR module is supposed to exclude, unlike the complex TVAR-EVAR module where it includes those types of things, the EVAR module is a little bit more restrictive. It says that you're not supposed to do paranastomotic pseudoaneurysms. That's an exclusion for an infrarenal EVAR repair in that module. And we've talked about whether or not that should be expanded, but it has at least to date been changed. So technically, that scenario with an infrarenal EVAR device remediating a previous open repair paranastomotic degeneration, that wouldn't qualify for the EVAR. But if you went higher and put in a fenestrated component or chimney, then it would be in the complex EVAR.
Yes, if it's infrarenal, then it probably will be excluded. But if it's one of the complex ones, there is an option that you can put it in. So, and I wish they will include the simple EVARs, because we see them more and more. My question is on the TVAR and complex EVARs. On the stage ones, that we have one portion done in one procedure and another portion done in another procedure. Me and many of my colleagues, we kept in touch and we talk and debate how things should be entered. And we have a situation with complications when there is a stage one, that we don't know how to put them. If the complication, like what will be the length of stay, what will be the ICU stay, when you have two different stay at the hospital, how do you add them? If you have a complication in one of the procedures but not in the other one, should we put them in one full procedure or not? Because right now, they have been telling us, wait until it comes to second stage and enter all the data. But then which length of stay, which discharge we use, which complications we enter, and which one we don't. So I would like advice from the panel on how to tackle those.
Can I discuss it, Lillian? I think this is, I sent Lily an email this week because we were debating a case similar to this. We had a TVAR done, say, in March of this year, more of a straightforward, had a landing zone. May, the patient came back for a complex EVAR. So we contacted Pathways and we said, you know what, these in of themselves would have qualified for two separate procedures if we were a planned stage. So we were recommended, well, the first one had the TVAR, so count that as your primary, and then put the second case, the complex EVAR, as the second stage. Well, the thing is, our second stage is the one that had all the complications. The patient was discharged to the nursing home, had kidney issues, all sorts of things, that if we had only captured the first one, those complications would have never been caught. I said, shouldn't maybe we consider counting this more in long-term follow-up as like a second procedure, return to OR, something like that, so we could catch those details. So after we explained that, they said, well, normally we would tell you to put that in that order, but since the second one ended up being more complex, make that your primary and count the previous one as a stage. So I just was a little bit confused by, like, how are we supposed to make that determination? I mean, if I want to take the easy road, I would just count the first one and have to do less complications and less work for me. But in trying to be diligent and capture things, I'm more inclined to count the second one, so to show more of the severity of the complications. So I think too much discretion is left to us.
And not only that, don't we want to see when things went well? In the first procedure,
Yeah.
things went well. We want to be able to tell, oh, this part of the procedure went perfectly well. How can we tell? Because we're entering the complications from the second procedure.
Yeah. How do we pick and
So
choose?
how can we tell?
I mean, it's
There's
actually,
bias.
it's actually a really interesting question, because that's a more and more common thing to be doing now. If you're doing a completely endovascular extent to, because this is really thoracoabdominal, right? So if you're doing an extent to thoracoabdominal aneurysm repair and staging it, which most people do and should, the least complicated, lowest risk part of that is the TVAR. as the first procedure, and all the risk is with the second one. I think if there's a way that we can assign the primary procedure to be the complex EVAR at the end of that, that's probably the right way to do it. But from a technical standpoint with the registry, I'm not sure how you make that work. But that's the way that those stage procedures go, that's for sure.
In my opinion, and as a suggestion, it should be entered separate, but then we should be able to put that there was a stage in using that field, that this is a stage and we put the date. That way you can refer to the other entry that you put separate.
And
So
they
you're
would both
able
show
to
up-
capture all the complications on the one that had complication and none of the complications on the one that didn't have to. And you have the reference by putting, this has a stage component, and you can look at the date and reference that. That's my opinion.
And both cases would show up on the claims validation, so we have to justify why both cases aren't in there. They have separate OR dates.
Exactly.
Actually, Dr. Shermorn's timing is impeccable because I know that he's done a deep dive on some of the analyses of these sort of staged procedures and trying to understand the vagaries of just trying to do good outcomes-related research. Is there anything that you found that is sort of instructive to all of us to sort of inform that discussion?
I would actually ask Tom O'Donnell right there to come to a microphone and explain to it, because he's actually the one who did all the work. And then my understanding of it is just what he has told me.
Dr. O'Donnell, tell us about stage procedures and the challenges that come with trying to study them in VQI, and maybe illuminate us on what you've actually found.
So this has been a pet project or headache of mine for the last year. So like you noticed, the VQI, you can log stage procedures in two ways. And if you look at how people log them, it is really an even mix. And so it's very difficult to tell who was staged, how they were staged, and the complications in between the stages and things like that. And so I think something definitely needs to be done about it, because right now the sort of analysis is almost untenable. And we're most likely missing a fair amount of cases. You know, the VQI is telling people you need to wait till the second stage and then log both at the same time. So there's likely patients we're losing who say have their TVAR die, never come back for their first stage. They weren't going to be logged until their second stage, and unless someone's very diligent about going back and re-logging them, they're most likely not going to be captured. Because of that, and then the logging of the second stage, we may be over-capturing events from the first stage. And I think it's very difficult to do any sort of analyses on some of these more complicated thoracos without a real understanding of what's going on. And so I think the simplest thing, I mean, personally, would be log both procedures separately. A TVAR is a TVAR, you log it as a TVAR, but you use that indicator that's a stage procedure. And we can see in the VQI, if you have a TVAR, then 6 months later, you have a complex EVAR, that's a staged procedure most likely. And so that's relatively easy to capture. So it may be a little bit of work, but I think it's by far the cleanest way of doing it. Anything else is just a disaster, which is what it is right now.
So I suggest if we're going to do it like that, please communicate to everybody so we are all doing it the same way. Because right now, there's some people that do it one way, other people do it a different way.
Yeah, we'll talk about it, and with the TVAR dissection project, where our hands are a little tied, but it also is an opportunity for us to have more time to really flesh things out and get them organized the way they need to be done.
Thank
Yeah,
you.
it seems something perfect for the committee and the chair of that registry to sort of take that question up and sort of how to tackle that in perpetuity of how to best sort of capture these data, because it's going to become increasingly more common, I think, as centers increasingly adopt more complex endograft strategies and consider, staged approaches, et cetera.
So we actually do a lot of those staged approaches, and we were told to do it opposite to what Dr. O'Donnell said, is that just log it all at once with your stages in between, so that, you might have a TVAR done, at some point, and then 3 weeks later, you've got the complex visceral segment done, but that wasn't my question. My question is actually regarding the EVAR module. We do an awful lot of IBGs, and quite, I know that it says you can go for the branched grafts, but quite often we're using more than 3 pieces, and we extend into the superior glute. So I'm wondering, what are the more important? Do you want more of the externals? Do you want more of the internals? Like which are the pieces that are more salient and more important to capture?
Yeah, so when the EVAR module was sort of modified about 7 or 8 years ago with the idea that this would come down the pipeline, obviously it would, there's second, third, now fourth order vessel sort of cannulation that's occurring. And so I think that, if you're getting into that tertiary quaternary vessel sort of revascularization from a quality improvement standpoint, I'm not sure how critical it's going to be. There are always the opportunity for comments to be put into the boxes, but it would be adding basically another radio button that would have to drop down to say, now you're going into a tertiary branch. I'm not sure. We could certainly discuss it in the EVAR registry committees to sort of understand how often that may occur. Because if it's a small fraction of the cases where that actually is a probability of occurring, it's not clear that a registry-wide change would necessarily be needed.
Going back to the staged, the problem that we have is when you have 2 separate physicians, one doing the arch vessels and the other one doing, the TVAR, is when you're doing a complication, and one complication could be assigned at the end when it was a complication, from the start, and it's not being assigned to that physician. For a center like us, we're unblinded for our complications throughout, all of our physicians. Dr. Smith that had that complication is now showing on Dr. Brown. And so that's a huge problem with us. Also, length of stay, stuff like that, is showing up on the wrong physician.
And great point. I mean, as a PSO, we don't assign complications to a particular physician. I know you're probably doing that more at a center level. But these are all great suggestions, and we're going to have to take this into consideration. So thank you.
I have 2 questions. The first is pretty easy. TVAR is recording vascular trauma for blunt aortic injuries as well. EVAR excludes repair from trauma, although if it's for occlusive disease in an EVAR's place, that should be done in PVI. So my question is, with increased violence and everybody is doing it, should we start thinking about capturing traumatic aortic injuries in some form? And where should they be captured? In PVI or the EVAR registry?
Yeah, I don't think there's a great answer for that, at least in my view. But if you go back to what it is, if you're talking about either a blunt aortic injury or you're doing an EVAR for, say it's a penetrating injury of some sort, maybe that came about, you've got flow outside the lumen, so technically maybe a pseudoaneurysm, so aneurysmal disease. So I would put it in personally, I would put it in the EVAR side, but Sal probably has better insight in that than I do.
Not especially. It's come up, the idea of expanding the criteria and trying to harmonize EVAR and TVAR criteria. There's just, I don't know that you can fully harmonize them for all the various indications that each treatment modality is sort of employed under. But yes, Gary, this has come up before about where this should exist, because not everybody treats those traumatic injuries with an aortic endograft, and then currently you have to select which endograft you use, and some people are using other types of stent graft systems that aren't commercially available EVARs, so then we'd have to sort of figure out how do we capture that level of information, whereas in the PVI, yeah, it has both as a potential option. So yeah, it's something we'd have to sort of talk with PVI with. We have not necessarily come to resolution on it yet. So.
Yeah, I understand the dilemma. The question I have for the panel is that we currently report back to our members regarding length of stay for EVAR and TVAR, and also EVAR sac diameter reporting. And those are pretty what I would call old or stale reports. They've been there for quite some time. Yes, they're proxies for other things to look at as to why your results are. But thinking about previous discussion, and we know that a lot of people are pushing the envelope on EVAR placements with short necks, anchors, et cetera. Would it be reasonable to have a quality report that comes back to an institution that has maybe done a X number of endographs over a period of time, over a period of 2 years, say, where these are the ones who you are now placing a complex EVAR device in follow-up? In other words, how many are failed endographs down the road? Would that be a reasonable or a good report to provide back to the members from that?
Just so I can, maybe all of us can understand it better. So to get the follow-up information, how would that be ascertained? Just because of the limitations of the follow-up as it exists now, how would we know that we'd have the right numerator denominator to know that we're giving them valid sort of assessment of what their failure rate might be? Just because there's a lot of missingness, obviously, with the follow-up. So how to capture that with enough fidelity that the centers could take that information back to understand that implication.
Yeah, and also whether to include it in a regional report or to submit it under benchmarking, where the center can do their own review of their analysis. But to me, I think it would be a useful report. We do have individuals within our own groups who are much more aggressive at treating short necks with EVAR. And then we're talking about what to do with them after they come back, with the type 1A leak. And we're not getting that feedback, I think, from a center perspective. It's hard from an individual perspective, but certainly from a center perspective, I think it'd be important.
But I think that's something you have to do internally. I mean, I just don't know how it's tough to get 1 year follow-up. I'm not sure how you're going to get 5-year follow-up and have it be meaningful, right? I mean, that's the big problem here is that who's going to abstract that, who's going to follow it. So I think in your own center, that's something that if you think that your partners are doing this too much, then this is where you got to sit down and say, maybe we're doing this and look at it at your own level. Because I just don't think at a national level we're going to be able to have anything accurate. And I don't think that like Medicare linking is going to be able to do that.
But I think, Gary, you bring up a good point. It's just the idea that there are certain feedback that we've been giving centers for a really long time and a lot across all these registries, and some of them we probably should not change, but is there an opportunity to further refine or improve? Is it these aggregate measures, these composite measures? How do we sort of use both the intake, patient selection, anatomic sort of selection, follow-up? Is there a way to sort of better define how care quality is being delivered across the centers at the center level? And has that changed for the center over time as their practices change? It's a really sort of provocative question to sort of gets at Mark Shermore's point. I don't know that we know what good quality EVAR is. Like we don't have a definition of it. I've always remembered Mark's phrase, you could do a lot of bad EVAR and nobody would ever know. No, honestly, I mean, everybody could have a type 1A endoleak and get percutaneous, they go home the next day and VQI, it looks fine. And if they are lost to follow-up, well, so are 50% of the centers losing follow-up. So your numbers look great, looks like you're doing great EVAR. And so from a quality standpoint, you have no idea. So, but then the question is all reintervention equal? There's just so many sort of layers to that. So I'm not sure what the composite measure will be to provide that feedback, but I do think it's an opportunity, and probably it's really what's the future of quality and aneurysm care look like? What should it be? And what should it be based on? Is it these old metrics, or is there some other better way that we should be defining it?
So I think part of where that may come into is, and I'll give a plug out for the verification program, is at least when we went through it from a pilot site standpoint, one of the things that came out of that is we kind of upped our M&M a little bit, we call POCMA, phase of care, mortality, and the patients like this that would come back for reintervention would probably would fall into be presented at POCMA, and then if we saw a trend in that, then our action item would be to go to our quality department and have them do a focused review on those patients and find out the information on You know, is there one operator where this is happening a lot, or is there one anatomic constraint that we're seeing that this is occurring a lot, or something of that nature? So that may be a way to do it. I agree. I don't think the VQI platform is the way that you're going to do that. I think that's going to be something more center-specific.
And the variables are impossible, right? So you take a 65-year-old, we can all have scenarios. 65-year-old with a 6-centimeter aneurysm probably should be done open if the neck's too short. 80-year-old with a 10-centimeter aneurysm on oxygen, you know, maybe they need to get anchors, right? Like you can come up with when you would do these different things for everybody. And so it's really hard then to look at what is the quality, what's quality and what's not based on each individual patient, because really our goal here is for them to die of something other than their aneurysm, right?
A couple of things. First, some of your voices we can barely hear from the back. I was wondering, when are we gonna have the field on the guidelines for aneurysms, so we can see if we're meeting all of the guidelines for aneurysms and not just some of them? Because right now we can tell when a patient is fusiform in the simple EVARs, but we cannot tell whether this patient had a saccular or whether this patient is a cancer patient. The other thing is, besides when are those fields coming, because we're really waiting for them, it's whether isolated iliac aneurysm should be captured. More and more we're seeing full EVAR devices used when there's iliac aneurysm with a normal aorta. And we're not capturing that in the EVAR, in the simple EVAR, and we're not capturing that in the PVI. So those cases are left blank. And we see them more and more often, especially with the branch iliac devices, that we're not capturing, we can't tell what happened, and the EVAR, simple EVAR, the module is perfect to capture that if it was included. So I wonder if that might be an option for the panel to consider including isolated iliac aneurysms for the simple EVAR. And I agree with the extra devices for simple iliacs. For branch iliac devices, we don't have enough. You have a minimum of 3 devices, and if you have to use 1 extra for a complication, you will never capture those. So, any news on all my questions? I know I asked a bunch of them.
So EVAR was one of the first 4, the original 4 that were in the Northern New England Vascular Study Group. Charter was like 2002, 2003. And I think Dr. Cronenwet and Jens and the seminal group that started all this work, iliac aneurysms isolated were less than 1%, and they still are epidemiologically. You might be seeing more of it because of more imaging, maybe. But, I guess it's more of a question for the larger sort of consumer. Do we want to add more to the registry? Changing the criteria for the registry is not that necessarily that hard, because we're not making a structural change to the registry. It just depends, it's sort of philosophically, how much do we want to put in these registries, because it makes it that much more heterogeneous also, right? And so from a quality standpoint, I don't have a dog in that fight either way. If there's some type of vote put to it, either Jim, Jens, Gary, Carolyn, et al. sort of takes up the vote from the consumers of VQI, and they say, boy, we want to add these cases, then it seems reasonable, particularly when there's not a structural change to the registry that has to happen. It's just a change in the definition of the inclusion-exclusion criteria. So it's from a quality perspective and relative proportion of population that you're treating. I think originally it was excluded because those are just such a rare, relatively infrequent entity of what's being treated.
The module is perfect for that. Right now, you can tell what is the size of the iliac aneurysm, and you can exclude it by capturing the size of the aorta. You can easily remove them when analyzing data. So it's just a matter of including it in the inclusion criteria. So.
I personally think that some people are already doing that, and I think that's one of the reasons why we have a very low rate of having patients above 55 millimeters or 50 millimeters for their indication for their aortic aneurysm. And we do capture the iliac diameter, so I think if you have an aortic diameter of 32 or 28, and you have an iliac diameter of 4 centimeters, then I agree, you can figure that out.
And that way you can capture basically all the aneurysm from the extremities, because you do capture the PVI, femoral aneurysm, and popliteal, so you might as well capture the iliacs.
Although we have to philosophically scale, so what are we doing here, right? Are we trying to have a quality metric for abdominal aortic aneurysm repair or all aneurysms? Because as you add things like, trauma, or you add isolated iliac aneurysms, you are going to affect the outcomes one way or the other from a quality standpoint. And the more heterogeneous things are, the harder it is for us to compare from center to center. So if I have a center that all I'm doing is distal anastomotic aneurysms and iliac aneurysms, I may have a better outcome than somebody who's doing complex short neck things. And so we're not actually comparing apples to apples, so it's really hard to know where you fall on the center if we're going to use this as a quality metric that we're supporting, reporting to our hospital. So that's the problem.
But that's why you can use the aortic diameter as one of the ways to exclude them if you're going to analyze just aorta aneurysm versus iliac aneurysm. You can easily do it.
Yeah, I don't think you can do that because there's other reasons to treat aneurysmal disease, even though they may fall below the 5.5 centimeters that's currently in the guidelines. You may have someone that has rapid expansion or some other pathology behind that is a true indication for treatment of that. And so those want to be included. So you can't go just by size.
That's why I was asking for the other metrics that it was mentioned in the previous meeting, the other metrics of the aneurysm guidelines from the SBS. That's why I was asking about them as well.
So you're going to hear as we go through the rest of the program, I don't want to give away too much, but we're re-engaging all of our registry committees. We're going to be evaluating every single variable. Every single variable. Each variable is going to be crosswalked to a reporting measure, to guidelines, to AUC. It's going to take, not going to happen overnight. It's not going to happen this year, but we're working on it, and we hear you, and you're right, it's important. But then we also want to be mindful that these registries are labor-intensive, and there are a lot of variables. So, it's finding that magic balance.
I understand.
So, but we're working on it, Lillian, and you're right.
And so just to add on to Carolyn's comments, we do regularly revise all of the registries. We take these comments into consideration, and they need to be updated. When we redo the EVAR registry, when that's revised, we'll include some of these guideline criteria, such as saccular aneurysm. We will include increasing size, which is actually not in the guidelines, but that will help us better define if patients have a smaller aneurysm, whether they met the guidelines.
So this is kind of inspired by the previous comment, but it kind of applies to all the registries. VQI is really good for 30-day outcomes. It might be okay for one-year outcomes. Do we as members have the ability to see what the number of patients are in each registry for 5 or 10-year data? Because truthfully for AAAs, right, you really want to look at 5-year data and 10-year data more than the 30-day data. So do we know what those numbers are, and do we have that? Can I say I'm going to do a project, but there's this many 10-year EVAR patients enrolled?
Anyone can put in a follow-up at whatever time point, and we encourage people to put in, follow-up after EVAR at 2, 3 years or 5 years, and I think we're getting somewhere around 10 to 15% of additional follow-up beyond those initial time points.
It would just be really helpful if you're looking for long-term data, because really, historically surgery was 5-year data points, right, 5-year outcomes. So I think if we're talking about EVAR and failure of EVAR, until you get to the 4-year mark, it's actually kind of meaningless because the natural history of disease probably doesn't extend. And so you put a compromised short neck and an 80-year-old, that patient might not live long enough to have a complication, but if they do, they might, because you're just really maybe treating yourself. You're not treating the aneurysm. Hard to say. But, I mean, I guess I'd like to know, before I submit proposals, is there a way when I'm logging on to know, oh, there's, 10,000 patients with 10-year follow-up? That's what I'm asking. For any of the registries, do we have that? Do we have the ability to put that on the website so you could know if you're writing a project?
Within the actual data that you get in the CSV, in the CSV file or the Excel file that's given to you, it's only going to include the long-term follow-up fields, which are usually that 9 to 21-month window. And as Jens just said, I mean, across most of the registries, we're even at that 9 to 21-month, 1-year follow-up window, at least for EVAR, you're missing 40+% of patients already. And so it just is going to be an asymptotic drop-off in that file, in that curated file that you get if you're trying to do some research question.
I mean, I get that
That's
there's
where
going to be attrition
vision-
rate, but
I
even
think-
10,000 at 10 years would be a lot of patients, right?
No, I understand the numbers thing. I mean, the registry has 60,000+ repairs. But again, when you start sort of looking at small fractions, is it representative of the larger population? The vision analysis, and that's what you can lobby for. If you go through the RAC, get a RAC-approved project, and you work through vision, there is an opportunity for selected centers, if you're participating in those registries, to sort of ask those questions and say, at least among Medicare beneficiaries that can be matched out of the VQI registry, and they're followed longitudinally in claims, can we get some type of hierarchical perspective on what the actual reintervention rates are, readmission rates,
Yeah,
et cetera?
for aortic, right? Because I've actually looked at this with the M2S database, and so if you really want to talk about AAA, we used to talk about cure. We fixed it, right? We fixed it and it didn't expand. So if you look at the M2S database, when I looked at that, it was in 400,000 patients, we excluded people in trials. It was like 0.016% where the aneurysm sac shrunk to 3 centimeters. But if you had shrinkage from a 5.5 centimeter sac to a 3 centimeter sac, what you really want to know is why did those people shrink and nobody else did? And maybe shrinkage to 3 centimeters isn't cure, but maybe it is. Maybe that's what our definition should really be. Or maybe not, because the other people aren't rupturing. So that's, I think, but I still think when you're saying, oh, you may only have 10,000 people in the registry that have 10-year follow-up, or maybe it's only 5,000. When you look at large centers and they publish data, it's still, you're looking at thousands of people versus 5,000 or 10,000. So just from a number standpoint, yes, you're getting a fraction of the VQI patients, but it still might be more robust than a lot of the trials.
But it's flawed, right? Because the problem with M2S, when you look at that database, you had to pay to send in your follow-up scans. So if your follow-up scan looked good and you weren't going to intervene on it, you didn't send them in, and because it cost your center money. And so that's why you had a higher number. There are some centers that send all their scans in, but that wasn't a very good fiscal
Right, I'm not
policy.
saying it's right.
But
There's
what I'm
flaws
saying
in
is,
every database.
so if you're going to have a selection, I mean, this was, I fought with M2S on this a long time ago at the beginning of my career, but all of these studies, if you're going to have sort of random follow-up, and even if it's a huge number of patients, you don't know why the follow-up is in there. So, I mean, I think if this is something you want to do, which I think is a great idea, what you do is you take 10 institutions across the country, get your friends together, take your individual VQI data, so you have all those patients, do the long-term follow-up yourself, pool them together, and get 10,000 patients. I mean, that's the way to do that study, because then at least you know what the long-term follow-up is individually at each institution. I think that's the way that something like that is going to be robust and give you real data.
So I guess just circling back, we don't publish what number of patients are in a 5-year follow-up, 10-year follow-up, 3-year follow-up. It'd be just nice to know the actual raw number.
It's just random is the problem.
I'm curious,
Something.
how many sites are doing, unless you're participating like in a post-market, surveillance study, who's doing more than 1-year follow-up? And what resources do you have and finances to
Well,
be
we all
able to do
follow our
that?
patients, right? So you might not be reporting more than 1-year follow-up, but I follow my patients beyond a year. Right,
But
so-
you don't put it in the.
Of course, but it went to what database?
Right,
Yes,
so
not
for
VQI.
aortic disease in particular, the anatomy matters, because short neck is a big deal, right? So that, and the length of the neck actually in my subset of N2S patients was the most critical part in failure. So, I mean, I think that's where the anatomy and the anatomic follow-up for EVAR is really critical.
Yeah, I was just curious if people were putting in past a year and how they had the resources to do that. I didn't even know it was an option. They don't.
One more question, and then we're going to move on to our next session.
Sure, sort of a two-part, slightly different question, but for the TVAR complex EVAR database, is there any consideration towards adding a field for laser fenestration? Because right now, there's no way to basically determine whether something is, a physician-modified fenestration or a laser fenestration, and there's a fair amount in the database. And just sort of going along with that as well, that is probably an area where there's a huge amount of miscoding is the coding of the interventions for each of those branch and fenestrated things. And about 50% of them appear to be miscoded. And so I think, number one, we probably need a laser fen tab, so we know when that's happening. And number two, there probably needs to be a broader education as to what's the difference between a stent, a stented fen, a fen branch, a stent branch, like the 17 things you can enter in the VQI. That either needs streamlining or a lot more education.
And going a step beyond that, I think we also need to be able to capture the debranching procedures, because if you look through the data from the Nexus and various other things, a lot of the strokes that are happening in these patients are happening during the index operation for the debranching, not during the TVAR itself. So I think it's a much bigger conversation than what we're going to have here, but I think we need to be able to capture both those things.
I agree.
Well, thank you, everybody. This will bring us to the end of our aortic session, and now I think we'll move on to our carotid session.